video. Lovely. Thank you. Thank you very much. So all the panelists, if you can, put your video on, which would be nice to see you. And I'm going to start with the question and answer session. Aoife, I might start with a simple question to you, just to kick us off a little bit with a clarification around the startling statistics of abuse that you mentioned from the States and from other countries in children and adolescents. And the question from one of our attendees was whether the prevalence rates were retrospective or whether it was cross-sectional and they were looking at current rates of abuse. And I was also interested, I'll just check, Aoife, are you?
I can't seem to start my video, Fiona.
Okay, Kellyanne, can you see if you can start Aoife's video, or maybe it's, yeah, super. You're good, Aoife. So the second thing, so one of it was about the prevalence rates, whether it's a retrospective recall or whether it's actually a cross-sectional current rate of abuse that they found. And the second question I had for you was with regard to the definition of abuse. I mean, obviously you have individuals who've had a single episode versus multiple, long-standing chronic abuse, the relationship of the abuser to the person, the personal meaning of the abuse. And then when you consider all of that in the context of other adverse lifehood experiences the individual has, how does that definition of abuse, you know, whether it's retrospective or current, how do you actually interpret that from a point of view of knowing what therapeutic input might be needed or the impact of that abuse might be for the young person?
Well, maybe I'll start with the first question. It was about the prevalence rate, and I'm not sure if it, because I saw it in the chat and I sent a response, but the TUSLA reports were actual reports that were submitted to TUSLA. So they are concurrent, you know, for that time period. So they're not retrospective. They are the rates of referrals of concerns of abuse. In terms of, I think the other data that I presented mainly would have been, I think, a mixture of both current populations that would have had a history of abuse and then monitoring or assessment of their clinical presentation. So the rates of, say, children from a pediatric setting that had a history of abuse that had clinical, you know, presentations, and then the other kind of international figures were I think really just counting the rates of reports and rates of confirmed cases of abuse in their child protection registry. They were the main ones. So I wasn't really talking about historical reports of adults of childhood abuse. I was talking about the rates of you know, reports of abuse for children, you know, you know, in childhood.
And in terms of how do you take those reports and then link them with the meaning of abuse to the individual? I mean, you know, there may be a report, yes, this child suffered physical abuse or sexual, but the need to actually look at the meaning of that event or multiple events or chronic events for the young person.
Yeah, well, I think that really is part of what the role in St. Louise's was about, was, you know, now obviously we only saw a very tiny proportion of cases that were referred, and we would have seen cases that where TUSLA had confirmed, you know, had done their assessment and referred them to the therapy service, and then we would, through the therapeutic approach, you know, meet the child. You know, one of our principal psychotherapists always said, we meet the child and the family where they're at, you know, so we're not insisting any particular meaning or any particular impact. We try and assess what is the the level of impact for that child, and what are the needs of that child. So it's quite an individual, I feel it needs to be quite an individualized approach. And often we were very lucky in St. Louise's and in St. Clair's to have a very well resourced therapeutic team that could provide, you know, a range of therapeutic interventions, both individual, family, and sometimes group interventions, parent work, you know. So it really has to be, I feel, guided by the child and the family's needs.
Right.
And obviously their clinical kind of presentation, because, you know, some children, you know, might be completely mute or non-verbal, and say sometimes that would involve working through a non-verbal means, play or art therapy. You know, we were really, really fortunate. I felt very privileged to work in a setting that we could. Now we did have, unfortunately, waiting lists. You know, there are obviously challenges as well in meeting needs, but, you know, to be able to tailor an approach, as well as consider the evidence base, obviously, and the trauma-informed CBT and EMD, you know, the eye movement desensitization, you know, they are all developing as well within those services. So we were able to tailor the needs to the individual child.
Thank you, Aoife, for that. And I guess just to put it back to our listeners is the importance, you know, when you read research and you hear those statistics, and the asker was right to, you know, ask, is it retrospective or not? But from Aoife's answer, you see, you know, the huge variation. You know, one person might have experienced a number of abusive episodes, but actually somebody else with only one, the impact might be so much greater. So it's very hard to extrapolate from some research papers to the meaning for a service and the needs of the young child. You mentioned, I'm going to ask Caroline a question. You mentioned, Aoife, the importance of non-verbal work and taking into account non-verbal children. And Caroline, one of the attendees asked that question about if they were working with a young person. In their example, they gave an 8-year-old child where, you know, language development might be much less. And I'm also thinking with the cohort of young adults that you work with intellectual disabilities, where not only language but intellectual understanding might also be a specific risk for them. In what way, you know, are trauma-informed care and interventions adopted? Might you say a little about that?
Thank you, and thank you for the question. I suppose there's no one answer really for this. Sure there isn't, because it's so individualized. So if we're thinking about a child, we're thinking about those 5 principles and how can they be evidenced in moment to moment. So we're thinking about safety at the breakfast table. We're thinking about safety when the child opens the fridge and their favorite yogurt is there. You know, so we're thinking about moment to moment, where the routines of the day are conveying that idea of trust, of collaboration, of choice, of love, of empowerment. So we're thinking about that kind of biology aspect of, can this child go through moments to moments in the day in a way that actually doesn't trigger a hyper or a hypo arousal? Because remember, we've a child who's going to be vigilant. So when your neurology is disrupted through a traumatic event, I mean, we talked about some of the endorphins that happen. We've talked about cortisol. We've talked about all of that. That's very real in the child's body. And it's actually very susceptible to being moved either into a hypo or a hyper arousal state. So we're looking at that in the context of moment to moment. So we would work with the circle of support quite a lot. We'd also think about, because sometimes the circle of support want to talk about it, and we're really thinking about the pace of the child. So we begin to maybe introduce emotional literacy a little bit. So the feeling of kind of being snug and cozy. So it's lovely when we put this warm blanket on us, isn't it? As we watch, you know, the Flintstones, or as we watch whatever movie we watch. So we're beginning to put language around those feelings of coziness. Or if we eat ice cream, I love vanilla ice cream too. So it's this type of introducing emotional literacy, emotional language. This idea of a stepped approach, because there are going to be times then that the child actually is going to need a protected space to play, to dance, to move in a therapeutic, creative therapy way. So we would find ourselves using this kind of interdiscipline approach where we'd have the circles of support, which can be family, can be carers, it can be maybe staff that visit and model into the family unit or the foster placement. And then we'd be thinking about protected space for the child, looking at maybe creative therapies. There are some lovely resources, the Books Beyond Words series that we might call upon if the child is interested in hearing a story that's secondhand, that's not necessarily about them, but that would be guided then by the therapeutic kind of context and pace of the child and the circle of support. So not an easy question to answer briefly, but I hope I've given you just a little flavour of what the approach might be that we would take.
I think we'll revisit that question. There's one or two other towards the end I'll come back to that I'm sure it'll cover some of those concepts that you've mentioned about, extending it beyond the verbal and using different supports. Emer, there was a question about accessing services and how can they be made slightly easier, because they can be quite intimidating for the best of us. But if you're actually approaching, from a trauma, it can be very difficult. And another related question was around the integration of services so that you could manage those 6 dimensions from the physical right through to the spiritual component of trauma-informed care. So any guidance for services to, reflect on that?
Yes, I mean, it's a very complex question. I can tell you what I would like to see, and what I think we should be aiming towards is that, say, in terms of accessing services that can be re-traumatizing because there isn't reasonable adjustment. There isn't an accommodation to the person who is vulnerable or who has a disability. And in that vulnerability comes where there's extensive trauma, you have a hugely vulnerable person in terms of connecting with other people, whether it's around form filling or asking for an appointment. So at a very basic level, what I think is actually needed is that just throwing out ideas of what might be possible is we look at advocacy services, because they have such a pivotal role in supporting somebody in navigating getting through services where they have a difficulty. Accompaniment by somebody who knows the person, preparation in advance. And I love that you mentioned the Stories Without Words, Caroline, because they work incredibly well for deeply traumatized people, children and adults, of people with disabilities, to actually, there's one about going to the doctor, going to an STD clinic. There are lots of very practical ones that help somebody prepare, particularly if somebody is neurodiverse. So there's preparation. There's how can the person be supported? Is that accompaniment? Is that an advocacy service? Also, I think what we do need to do in services, in public health services and in public offices, there needs to be a designated person who is a specialist helper for anybody who has a vulnerability, that has been taught specific skills around how to support somebody in engaging with that service. And that brings me to education. And I think perhaps, and here's a pipe dream, perhaps, that every service as part of their induction, and actually, Vicky, you mentioned this, is there should be psychoeducation around trauma, what it looks like, how somebody gets belligerent out of fear or becomes silent out of fear, and how to actually understand that behavior from a trauma point of view and to de-escalate and to be able to support the person to regulate and to move forward, to be able to engage with whatever service. that is. I think that's the first bit. And I can't quite remember.
Well, the second bit in some ways is about the integration of services. So that, you know, they can cover all the components.
Yes, I think we have a major problem in this country, and we don't have joined up thinking.
This country being Ireland or the UK?
Ireland.
Okay.
Sorry, my accent might be a little misleading.
Just clarifying.
Irish born with a UK childhood.
Okay.
Yeah. I think, I suppose my personal experience as a psychotherapist, where I am helping somebody who's deeply traumatized, and the first thing that I need to do, say, is find a history, or to integrate different services that hold different pieces of information, and there's very little flow, there's very little continuity of care, and I think it's something that we urgently need to look at, and to find ways to create connections that are person-centered rather than organizationally centered. It's a very big ask. I have lots of ideas of how that can be done, and I would take a day to tell you.
Well, I'll move on in the interest of time, but I mean, one of the biggest, most fundamental barriers we have is the lack of data collection and IT services. So we're hearing all about that, sadly, to our adverse effect in the media at the moment. I'm going to ask the next general question to Vicky, and if you would allow me, I might have one or two last questions for anybody who wishes to stay on. Vicky, following the Ukraine crisis, I mean, what we were experiencing was a recognition of this huge trauma, individual, collective trauma, but and coming to our services as well. But in addition to that was the lack of understanding and our lack of ability, not only to speak the language, but perhaps understand the culture. From your perspective and your services in the UK, could you say something about preparing and using interpreters, and also maybe the risks about assuming to use family members or siblings who've got better English is acceptable in doing the trauma work?
Yeah, so we're really lucky in the UK to have a very diverse staff team available to us. And what we do is, if we've got access to different speakers of different languages, we drop in on those people, shall we say, to translate for us. If we're not able to do that, then we use translation services such as Big Word and Clear Voice, which our staff have all got access to. They have PIN numbers, and then they can access those translation services at any time throughout the day, when people come into our services, and, you know, throughout the time of support. The issue with using friends and family to translate is that the confidentiality, and also that the conversations can become quite emotionally charged. The family might have a view on certain aspects of the person's support needs and things and that. So we try not to use families for that. But yeah, you know, it is a big ask, but the translation services we've got a really good relationship with them, and that's how we're getting through things at the moment. Yeah.
Thank you. The last question is to anybody really who'd care to comment, and it's one of vicarious trauma. We're all, as clinicians, exposed to the trauma, the stories of our patients. There's a risk of us becoming guilty about it, what we're witnessing, and maybe why we're not doing anything, whether it's learned helplessness or whether it's, you know, lack of knowledge. You become maybe emotionally over-involved or disillusioned yourself. Has anybody got good examples of how services can consider vicarious trauma for staff that works in their organizations? You mentioned, I think it was, I don't know if it was Caroline Emer, about psychoeducation and the importance of, you know, being alert to the possibility of trauma. Any comments on that? Emer?
Yes. I think it's an area that's a growing awareness that it's vital that staff get support for the health not only of the service user, but also for the organisation. And I think the best way we can do that is by offering, first of all, I think training at frontline level around understanding trauma, understanding our own responses to trauma, and how we become reactive, and explaining the psychotherapeutic aspects of transference and countertransference, where we pick up other people's feelings, and if we are full of fear from their fear, we will be reactive rather than reflective. So I think it's those providing the psychoeducation of the neurobiology of trauma, what happens to us which is normal and is actually a healthy response in one way, that of course we're going to be frightened, or of course we're going to be really angry in response to somebody, but to actually give staff that understanding of why they're feeling that way, how to regulate themselves, and how they can regulate other people in terms of everybody becoming reflective rather than reactive. And I think that is not just an initial training, but an ongoing provision of a reflective space that is not connected to line management, that gives people the freedom, the safety, and the containment to be honest and open about the feelings that naturally will come up when you're facing other people's trauma, and also to provide individual support for staff who are struggling, and teaching staff what kind of things to look out for within themselves as the signs that now I'm becoming burnt out, or now I'm becoming I'm experiencing secondary trauma. So I think it's all around psychoeducation, and that can be done within services, generally with the resources that are already there. I think it's time is probably the biggest resource that causes the difficulty in providing it, but it's possible.
Caroline, did you want to come in on that?
I mean, Emer took me there, which is this idea of the reflective space, because it's not in any way that we're thinking about that staff need, their own care plan or anything like that, but that we're actually having that stepped approach with staff that thinks about reflective space, that isn't line management in the context of operational day to day, but actually what is it like in this space for you, and how do you think about that in a way that is reflective, constructive, collaborative, resilient building. And I think we've some nice examples of that across the health sector, but they're often initiated by very key staff that have an interest in this area. It isn't something that we actually put in place as standard. And I'm just reminded very briefly of some very complex work where the team actually had that reflective space, and they had the plan around the child, and the line manager was then supported separately, so that if we're working in very complex areas, sometimes that's the resource that's actually needed. So just to kind of, compliment Emer on that and taking me there as well. Thank you.
Yeah, and to either of you, or indeed to Aoife or Vicky, in terms of the monitoring of the individual, I mean, let's say I'm working in a service, my service is very good about that, psychoed, and there's resources there, but nonetheless, I really am struggling with the case, or, the counter-transference is too emotionally explosive. What's the best way to also protect the case or the family that you're working with? So is there a way you can build into a service that evaluation of making sure that it's working and that each person is adequately protected?
Well, yeah, Aoife, do you want to come in there?
Well, I suppose I kind of echo what everyone is saying, really. I think it is that kind of layered approach, so that, there's an opportunity for individual supervision. And I suppose, I know sometimes, I think it's important that there are kind of layers of and different mechanisms in a way within a team, because I think that working with, particularly if it's particularly if a team working directly with trauma, you know, which is essentially its whole function, needs really robust supervision and capacity to process that. And then I suppose if it's in more generic teams, I think actually the teams that are working most with trauma probably have more of those resources, and it's probably more the generic services. I know in pediatric hospital, we're bringing in that balanced group approach and the Schwartz round approach, and that is all kind of developing now to allow a broad range of staff benefit from a reflective space. And then I think where we have services that are possibly more like Vicky's or you know, the trauma specific services really need a really high quality supervision, and as you say, almost like who's supervising the supervisor, and you need that openness to reflect on one's own practice as a supervisor, and that takes, you know, I know, and I think what Caroline is saying, because I've had experience of, you know, both being in the team reflective space and not in it, and you know, it really trying to work out some of that is really important, and it might get, you might get it a little bit wrong, and it's, you know, but actually I think what really important is as practitioners that we're able to say, well, actually this isn't working for this particular situation, and I wonder why that is, and being able to reflect on our own role in a case or in a team dynamic or in an organization, and actually that, even just that idea of stopping and breathing, as you know, that idea of the sunflower, just even doing that from time to time helps us to, I think, regulate ourselves within our work, within our, you know, all those interactions. I don't know, does that make sense, Fiona?
No, it does, absolutely, Aoife. And I think, you know, that whole concept, you know, like as clinicians, and we know this from the literature, you know, the level of presenteeism where you should be at home looking after yourself. You're sick, whether it's a chest infection or stress related to your work or over-identification with your patient, that clinicians continue to come to work until they reach that performance cliff, and then they're gone. And unfortunately, that is not good, neither for you nor your patients. And it's about how can we not feel bad about saying, I'm struggling, I'm not coping, this is not working. So it is, you know, it comes easier to some people than others. And I think it's important that, you know, we reflect more on this and maybe revisit some of this going on. I'm also mindful I'm eating into everybody's evening, and I'm doing the exact opposite of what we should be doing, which is a little bit of home sweet home, have that cup of tea and relax. And I don't want to take up any more of your time. We're already a little bit over time. So I want to end this wonderful session by thanking all the speakers very much. You gave lovely presentations, very thought-provoking and indeed informative. I'd also like to thank the attendees who've given up of their time, and I hope you enjoyed it. Please do let us know about other topics that you'd like the St. John of God Research Foundation to host on an evening, and give suggestions about timing and all the rest of it. I'd like to thank the St. John of God Research Group, Leslie, Kaliani and Peter for hosting this very successfully. Garamila Maga, Clodagh there behind that lovely spring tree, reminding us all of hopefulness. Clodagh was very helpful behind the scenes as well. And just to say to everybody, Ihawa agus Slán go fóill, we will be back again. Take care, everybody. Over and out.